Evening all. Back on the bike, as it were. 2 weeks off due to, actually no, it was 1 week, wasn't it? It was half term. Feels like two. It is amazing the difference. I don't know if I've said this already, but I read in a book the true measure of time is change, and I do really think that is true. When you do stuff like have a week off and stuff happens, it seems that time's a lot longer than when you just do the same thing all the time. Like a normal week would just go, don't they? They pass. But the last oh god, Jackie, I'm about to remove you there. The last week, hi Corin, yes, had a lovely week. So yeah, I went away for a few days and that's about it really. Oh no, went to London as well to see my brother and my mum. So Christmas present here. Got a Christmas present jumper there from my mum. Oh god, Chloe, I've got to remove you pressing the wrong button. So so yes, hope everyone else has had a nice break. If they've had a break, I know the half terms are at different times, and clearly, obviously, some people don't even work to half terms if they're just not got children. I'm very pleased that you can't see the floor behind me because I started to clear the bookcase, and oh my lord, Arthur, I've started and I'm not. I've given up. So it's in a bit of a state, but fortunately my body is shielding you of that that scene. So what's going on, you may ask? Well, I'll tell you what's going on. I've got some questions which I'm going to answer live on TV because that's how I roll. If you've got a question yourself, ask me and I'll answer it live for you. But if you haven't, sit back, relax, and enjoy the ride because this is going to be one hell of a session. Actually, it's not. It's not that many. Oh yeah, there are a few. We got a few questions. That's good. So, but feel free to chip in at your leisure. Don't wait for a gap because I'm just going to go. And here I go. I had surgery. Oh, you know what? I had surgery. Sorry, I had surgery previously, and I've been left with a scar across my abdomen. Can you offer surgery? Now, I think this is the one where I've got the photo. I normally write the photo in square brackets. Before that, hold on a minute. Corin's got a question. Hi, JJ. How big can dog ears be after a TT? How big can dog ears be? How big can they be? Huge. All sorts of sizes, Corin. They can range from very big to a very small to imperceptible. So the first thing I'd say is you need to wait at least 3 months to let them settle because sometimes there's a bit of swelling. And the way to fix them is to make the scar longer. So you can cut them out and you make the scar longer. There's always a risk there might be another dog ear, but it's going to be a smaller dog ear and hopefully an imperceptible one. But yeah, you can get a variety of sizes of dog ears after tummy tuck, ranging from imperceptibly small to big. And it kind of depends on how much skin you remove. The more skin you remove, the more that angle is going to be. So that angle like that, when you stitch that together, you're going to get a bulge. Whereas if the angle's kind of like that, then you're not going to get a bulge. So if you make the scar shorter, you're going to get a higher angle. If you make the scar longer, you make a smaller angle. So it's always a balance between shorter scar, smaller dog ear. And we have to make that balance and hopefully get it right. But sometimes you do have residual dog ears that need to be removed. But it's a relatively easy thing to remove a dog ear. Chloe, hope you had a lovely break. I went swimming for the first time since my up yesterday, and it still felt pretty uncomfortable to move my arms in the water and felt weird in my chest still. Is this okay? It is, Chloe. Crikey, when was it? Was it around Christmas time? Was it? I don't know how long ago it was, but it is. And I'll tell you something, Chloe, it can take ages for it. I think it's fine. The first thing I say, I think it's fine to do stuff. Obviously, if it's like painful, don't do it. But just if it's uncomfortable, I think it's okay to do it. But particularly when it's under the muscle, it does make it a little bit more uncomfortable, Chloe. And there you go, 19th of December. So yeah, so a couple of months. So it is not unusual. And depends on what sort. Now, if you're doing breaststroke, maybe not so bad. But if you're going for the full-on, front crawl, then obviously that's going to be a bit more uncomfortable. So yeah, just listen to your body, Chloe. If it's uncomfortable, back off and do less. And because you're still in that phase where you might get a bit of swelling if you overdo it. But completely nothing to worry about. But if you are worried, you know what to do. Call me, and I will be very happy to see you and check everything. But it's not an unusual thing what you're describing. So yeah, we got one with a photo here. So I had surgery previously, and I think this is the one with the photo. Got to check. Yeah, pretty sure. Yeah. Okay. So I've had surgery previously, and I've been left with a scar across my abdomen. Can you offer surgery? Now, very kindly, this patient has allowed us to show the photo. So I will. They are opt-in the same day as me. Oh, there you go. Well, look at that. You've got an opt-in, Chloe. So I'm going to display a photo now. Oh, am I in the way there? So this patient has had surgery. I think she had surgery when she was a child, and was kind of asking about scar revision. I don't know if I can move myself. Can I move myself? Oh, no. Oh. Yeah, okay. So she's got a midline scar as well as a lower abdominal scar, so kind of like a inverted T-shaped scar, as well as a dented in scar on the left side of her abdomen, which is presumably from a drain, which you can't see on Instagram because I'm in the way. Can I move myself? Oh God, no, they're not. So yes, this is a one that I would say would be a good option. May well be a tummy tuck for this, and I think this patient brought it up. I didn't sort of bring up a tummy tuck because all of the skin from the belly button down to the pubic area gets removed. So that scar, it's hard with photo. We've got other views, but it's hard without sort of assessing the tissues because there needs to be enough skin laxity in order to get the skin above the belly button down to the pubic area, because ideally we really want to excise all of that scar, particularly the vertical scar, the scar that goes from pubic area straight up to the belly button. And it's hard to see where the north pole, if you like, where the highest point of that is. I think it goes slightly above the belly button, and from what I can see, I think it does tend to peter out, because ideally we would get all of that scar, because if we couldn't get all of that scar, and if we just skirted the top of the belly button and there was a little bit of scar above, a little bit of the old scar above, and then we pulled it down and stitched it, that's the tightest point centrally. And so there's a risk that that could break down, particularly if you're stitching scar, if that's scar tissue that you're pulling down and closing under tension. So that would worry me a bit. I'd be a lot more comfortable if I felt that I could get to all of the scar out, but that would only come from an assessment to look at the skin laxity. The scar in the lower area looks good. It looks like it's in a similar area to where you would have a tummy tuck scar. So then you would go a little bit below that scar in order to cut that scar out so that all the scars are removed. So so that it potentially would be a good one for a tummy tuck kind of scar revision. Quite an extreme thing to do a tummy tuck scar revision. So you'd have to kind of want a tummy tuck, because if it's just purely the scar you're worried about, I think there's some lateral views of this which show the scar, the lower scar is a little bit puckered in, and so there's a bulge. So you could do something to try and just address the bulge, but I think that probably the best, if appropriate, would be a tummy tuck. But as I say, not everyone's a candidate for a full tummy tuck, because a full tummy tuck would have to get all of that scar, all of the skin in the upper abdomen would have to stretch all the way down, and things like that scar from the whatever it was, the drain on the left side, which you can't see on the Instagram, is potentially going to be a bit of a nuisance. But anyway, I think on paper this looks like it might be a potential one that you could get a really nice result. I don't know, a few of these patients with those midline scars with a bulge on either side, it's very unsightly, and a tummy tuck can really transform the abdomen because it completely removes that scar. But as I say, it would depend on how far up the scar goes, and it would depend on how much skin laxity there is going on. But on paper, very, very nice one for potentially for a tummy tuck to do a scar, kind of a scar revision, and also abdominal contouring. As I say, I probably would want to have the patient wanting the abdomen to be contoured as well as just fixing the scar, because there's probably simpler ways of just fixing the scar. How do I get rid of it on Instagram? Choose it to stop sharing. Yeah. What's going on in the chat here? I'm losing control. Doing really, we are well. Love, Chloe, op twins, same day. Or are we? Love that. Hope you're recovering well. Yes, doing really well. Thank you. I was an asset for a full TT with JJ on 19th. We were probably neighbours. Do you have a surgeon of your practice for blepharoplasty was about to book in, but the surgeon had left? Yeah, we yeah, thanks Fairy Dust 1970. Yeah, sometimes the surgeons at the clinic do blepharoplasty. The problem is, well, not the problem is, but the fact is I don't do blepharoplasty, and we've sort of gone up and down with how much facial work we do at the clinic, and really I feel comfortable with the stuff that I can do, type of thing, you know, having other surgeons working in my name doing the things that I do. So we're not at the moment doing facelift, rhinoplasties or blepharoplasties at the clinic. Fairy Dust 1970. So the answer is no. So we don't do blepharoplasties at the clinic, which is, I don't know, it's one of those things which well, anyway, this is a decision I've made. I mean, the blepharoplasty is quite a simple, or relatively simple operation. I mean, there's always problems you can have with any operation, but it's a relatively simple operation with quite a dramatic results. So it's a good operation in that respect. It's a very good operation to do, and it has very happy patients. But yeah, not doing the moment. We have in the past, as you say, Fairy Dust. So we have in the past, but we don't at the moment. So yeah, sorry about that. So yeah, I don't know. Are you in Birmingham, Westbourne Centre maybe, or somewhere? It's hard now. Plastic. I don't know where to do plastic surgery because all the hospitals are saying they won't do plastic surgery. So it's hard to, you know, normally I'd say ring up your local private hospital and talk, and, you know, see a plastic surgeon, but they're not letting us work at the private hospital. So goodness knows what's going to happen. Goodness knows. We probably were glad you're doing well. How are you doing after surgery? JJ is an absolute miracle worker. Thank you. I'm doing really well too. I'm so happy with the results. JJ is amazing. Yeah, thank you. Abs has joined. Thank you. I'll contact you to discuss further. Oh, was that the abdomen? Maybe. Yes, please do, if that was your abdomen. But even if it wasn't, contact us to discuss further, whatever it is. You're welcome to contact us and discuss anything you like further. So when having breast augmentation, how do you decide to go over or under the muscle? Right. So what I always say to patients is there's pros and cons of both. And there's pros of putting them over the muscle because it is a less painful procedure. There's less risk of them sitting high, wide, animation deformity, which is when you exercise, the breast moves. But they can be seen, sometimes you can get rippling, you can see them if you are quite slim. So if you're quite slim and you can, particularly if you can see your rib cage, then you worry about getting rippling of the muscle of the implants. So therefore you might put them under the muscle and put behind the other muscle has a risk of them sitting high, wide animations, more painful, more risk of hematoma. So there are basically risks and benefits of both. And so personally, I decide based on how much soft tissue cover you've got, and kind of in a way a little bit based on type of implant you have. Smooth implants are a little bit more likely to ripple than the textured or the polyurethane implants. So a smooth implant will be more likely to be put under the muscle. And so I will have a view, and but I always discuss it with the patients, and we can certainly have a conversation about it. If the patient's got a view, these days and age, patients have got a lot more of a view than they used to have. Old days, they didn't know what implants they were having, they didn't know where they were putting them and all that sort of stuff. Now people are much more informed, and so I'm very happy to have a discussion with you about it and to discuss the pros and cons. And there have been situations where people have said, you know, I've said, you know, I want to put them on top of the muscle, and they've said they want to put them underneath the muscle. I'm like, okay, fine. So as long as you're aware that there are risks with doing that, but there are, you know, obviously benefits with doing that. So it's a bit, you don't want to be too sort of prescriptive about it and say like one's better. You know, you always got to be worried when someone says one's better, you know, under's better or over's better. It really depends on the implant you're having to a degree, but more so your anatomy, your soft tissue cover, and it's a balance of risk. And, you know, sometimes you put them on top of the muscle, you get ripples. Sometimes you put them under the muscle, you get animation. So you do, and you think, oh, crikey, I wish I put it on top. But maybe if I'd done it the other way, I'd have got the other problem. So it's the life of a plastic surgeon. Why do we do it? You ask yourself. I don't know. I really don't. It's a hard life, you know. It's a hard life. I mean, Terry will tell you that. It's a hard life, and yeah. So under or over the muscle, and the other, I always say to people, go and get different opinions. The problem with sometimes one guy will say you've got to have it over, and then the other guy says you've got to have it under, and you know the other guy says you've got to have a dual plane. You're like, what, dual plane? Is that both? Well, no, dual plane's basically under the muscle, but there's kind of different types of dual plane. But I won't really get into that. Really, it's not really for a lay person to be too involved in. But yeah, it's so the answer is I will have a view. Whether I put it under or over, I will express that view with you, and we can come to a mutual agreement on what the best balance of risk would be, because it is all a balance of risk, and we're just trying to do the right thing, and you know, trying to get it right. That's the game. What we got here? What's going on? I will. Yeah, yes. Hiya. Other than scar revision, are there any other treatments you offer for surgery scars? No. Loco lupulus. No, we would only offer surgical scar revision. So there are other treatments for scars. So if it's not a suitable, or if you don't want to have sort of more surgery, because it's all a bit weird saying surgery for a scar, because you know you've got a scar and surgery is going to give you more scarring. So yeah, it's probably good to explore non-surgical treatments for scars before coming to a guy like this guy. It's got 2 thumbs and speaks French. Moi. You know, so you're better off having so non-surgical people do things like needling and derma roller and you know, all sort. Well, we would talk about massage and silicone gel if it's a hypertrophic raised one, but laser sometimes if they're red, and there are treatments for scars, but we tend not to do the non-surgical world of scar manage. Well, okay, well we do. Okay, I thought this. I'm prepared for this one, Loco. So, I mean, we do scar management. Obviously, when we make scars on people, we manage scars. And the fact of the matter is, most scars settle well just with a bit of moisturizer and massage. That's the main things I say to people: moisturize, massage, don't smoke, drink plenty, and avoid sun exposure while the scar is red and active. But yeah, but if it's a mature scar that you want a revision for, so like a year or older, there are things that non-surgical people do that we don't do. I think that's pretty clear. I think you all agree. I think I answered that one pretty clearly. Pretty happy with myself there. Are there any reason for someone not to be suitable for breast augmentation? Oh heck. Have you got something in mind? Not suitable for, well, they don't want one. That'll be a pretty good reason. Overweight people, very high BMI, you would be concerned about doing a surgery like that. But the thing is, overweight people probably wouldn't want a breast augmentation because they usually got large breasts. So that's not really a situation that arises. Smoking is a sort of relative contraindication, so you're better off not smoking because it can affect your wound healing. But it's not too much of a wound for a breast augmentation, but still that's a relative. So I wouldn't, you know, some people might make it an absolute contraindication in that they won't operate on smokers, but you know, others would make it a relative thing that they'd advise you to stop smoking. I mean, if you're not an anaesthetic risk, oh, we had someone. That's right. We've had someone with sickle cell disease who we said, it's mainly the anaesthetist who would stop you. So if there's a medical conditions, we've had another patient recently who had a cardiac arrest, has had a cardiac arrest in the past, and so the anaesthetist wasn't happy with that. That might depend on the hospital you're operating on. There might be some hospitals who would be happy with that. But so there might be some comorbidities, some medical conditions that you might have that would mean that you would not be suitable. But I think they would mainly be anaesthetic rather than surgical. I guess somewhere where you're making the incision, if there's some problem with the skin, if you had some very bad eczema or something in an area where you're making the incision, you would probably not want to do that because of the risk of infection. Yeah, I can't think of many reasons that you would not be suitable for breast augmentation. If your weight is fluctuating, you're not happy with your weight, or you really want to be stable with your weight. But yeah, well, I thought of a few there. Oh, pretty good. After breast reduction, are there any reasons for someone not to be suitable? So you mean after breast reduction, could you have a breast augmentation? Yes, you could have a breast augmentation after breast reduction. Yeah, I mean, obviously, that's presumably you've over resected, or maybe you've had a breast reduction and lost weight, or your body has changed. But that would be fine having a breast augmentation after a breast reduction. I can't see a particular problem with that, as long as everything's stable and it's quite a long time ago you had your breast reduction and your weight stable, etc. But in principle, that would be fine. Do you perform 360 lower body lift, and what's your BMI cutoff, please? So yeah, so there's different things in terms of a 360 procedure for the trunk. I don't really do the low, so I'm not pulling up the thighs. It's like a circumferential abdominoplasty or a belt lipectomy. So it's basically a tummy tuck that goes all the way around. So if that's kind of what you're thinking of, then yes. It's a very big operation, so it's something that is not a common procedure, I have to say. It's only for people who have lost a lot of weight. And one of the problems for people who have lost a lot of weight is often their BMI is quite high. So you're asking for a BMI cutoff. So if you ask for a BMI cutoff, just as a figure, then the figure is normally 30. The problem with a lot of patients is that they often have BMIs above 30, but they may have had it like way high. They may have been 45 and they come to 32, and it's like, oh, you need to be below 30, and it's like, oh well, they come from 45. So we will take everyone on a case by case basis, but 30 is kind of where you want to be. Really, that's sort of absolute number, but also comfortable and stable with your weight, which is also very important, that you are stable with your weight, that you're comfortable with your weight, because if you want to lose weight, you're better off doing it before the surgery, because if you lose weight after the surgery, you have some redundant skin, and you've also got a higher risk of complications at a higher rate. So even if your BMI is below 30, if you want to lose weight, if you're still losing weight, you're best to do that first. What we got? After having surgery, how long until you can return to the gym? Well, I guess it depends on what surgery. Not specified what surgery. So, I mean, I say obviously, if it's like minor surgery, like a mole removal or something where your skin's not under much tension, and you've got a little wound, maybe a week off, just have a dressing on maybe and stitches. You don't want to put too much tension on them. I'm assuming it's going to be like a major surgery, like some kind of breast surgery or abdominal contouring. So, lost you. My signal's awful. I hope it's not my signal. So I'm assuming it's going to be something bigger than that. So I normally say for most surgery, you can return to the gym. Walking is good straight off the bat, but clearly walking isn't returning to the gym, or at least you can walk to the gym, but just carry on walking past. Don't actually go in the gym for a couple of weeks. I normally say 2 weeks. I mean, it depends from people to people. Obviously, if you have a wound healing problem, if there's an issue, then you may want to leave it a bit longer. But normally, I would say 2 weeks is the norm. And then I normally say like lower body stuff, like exercise bike and a cross trainer, but with just your legs. most of the surgery that we're talking about here is going to be like breast surgery or tummy surgery. So you've got core muscles and you've got the pec muscles. So you really don't want to be putting pressure, putting tension through those until things are a bit more healed, just because you're going to make things swell and you're going to put tension on your wounds. So you kind of want to wait for about 6 weeks for that. And then after 6 weeks, then you can start doing a bit of exercise with your upper body and putting power through your upper body. But I always say to people, start doing that. You don't want to go full effect at 6 weeks. So just start gently, because it can make it swell. It can make it a bit uncomfortable. So you're better off just waiting until things are feeling comfortable. So just do a little bit at 6 weeks and then see how you feel. And if it feels okay, then you can build it up. So 2 weeks for the lower body and then 6 weeks for the upper body, basically, in a nutshell. We've done that. Sorry, how long does a tummy tuck op take? There are different types of tummy tuck, but the most common tummy tuck is a full tummy tuck, and I think that's what we're talking about with you, Jurgen, is a full tummy tuck. So 3 hours is kind of the easy answer to that. Sometimes you do liposuction to the sides, hips and flanks. That might take a little bit longer, 3.5 hours. So I guess 2.5 to 3.5 hours is kind of is the normal kind of time for a tummy tuck. But it is quite a big op, a tummy tuck, and it does knock you back because it's quite a long anaesthetic. So yeah, 3 hours give or take is what I would say. I'm back. Thank you for answering my question. I lost you part way through. What was your question? 360. Oh yeah. So the answer was 30. Was the BMI. Ideally, you've got to be stable with your weight. Sometimes you do it when people are above 30 if they've lost a lot of weight. Sometimes you would advise someone who's below 30 to lose weight if they still wanted to lose weight. So it's not a written in stone thing, but 30 is kind of the number that most people talk about in terms of BMI. JJ will place the replay after the live. Hopefully you can catch up there. Yes, I will indeed. I think it does do it there. Thank you for that, Corinne. I think it does do that. I think it does it also. Do I post it? Or it just does it automatically? But anyway, yeah, there is a replay anyway. I don't know if you can scroll through it or just don't really watch it all. Get to that bit, do you? Maybe you do. You know, gems that I've been what's the word? Giving out. Distributing. Jim, done that. How long? Why can't you have inverted nipple correction at the same time as breast lift? Because a breast lift moves the nipple from a low place to a high place. Same with the breast reduction. So it moves the nipple from a high. Everyone gets a bit confused with this. So a breast lift and a breast reduction is moving the nipple low place to a high place. So we have to cut around the nipple. So an areola reduction is an integral part of a breast lift and a breast reduction. However, so the two things you do to the sort of nipple and the areola are an areola reduction and an inverted nipple correction. So in an areola reduction, you don't have to ask for an areola reduction. It's part of a breast lift and a breast reduction. An inverted nipple correction, where the actual nipple, the bit that sticks out, is sticking in. I personally, I don't know what everyone else does, but I personally don't do that at the same time as a breast lift or a breast reductions because we're moving the nipple from a low place to a high place. We worry about the blood supply and the nerve supply to the nipple, particularly the blood supply. You don't want the blood supply being affected because then your part or even all of the nipple can die when you do a breast lift or a breast reduction. It's a very rare complication, but it is nevertheless a complication of breast lifts and breast reductions. So I don't mess with the nipple in terms of going in there and doing an inverted nipple correction because you have to cut the ducts and you have to mess about with the blood supply. And I don't want to mess up the blood supply even more than an already compromised blood supply because the nipple's been moved. So that is why I won't do an inverted nipple correction at the same time as a breast lift. I would advise you have the breast lift first because the breast lift can also can sometimes actually invert the nipple. It can pull the nipple in when you move that nipple up. And so it's better to do the breast lift first, and then later on we can try and evert the nipple once everything's settled. So if you do have an inverted nipple and a breast lift, you're probably better off having your breast lift first rather than your inverted nipple correction first, because if you had that and then have the surgery and then it pulls it in and the blood supply of the nipples altered and stuff, could be an issue. So breast lift first, then breast inverted nipple correction. Do we offer ear pinning reversal? No. Ear pinning reversal, God. No, I'm trying. I don't think I've ever seen it. An ear pinning reversal. So they obviously they've overdone it. Pulled. God, no, I haven't. You probably want an ear specialist for that. Now, Mark Lloyd, I don't know how much he's doing these days. Keep on seeing stuff on LinkedIn about him doing all this property stuff. But Mark Lloyd is a plastic surgeon who is a specialist in ear. There's a few ear specialists out there. Mark Lloyd's someone I know. David Galt is very well known. I don't know if he's still practicing. It might be old, retirement age. There's probably others, but Mark Lloyd sort of was based in Birmingham. So you probably want to talk to an ear specialist for that. But is that even a thing reversal? I don't know, Corinne, to be honest with you. I've never seen an ear pinning reversal. I mean, I guess they've overdone it and like made your ear kind of stuck back to the side of your head, like really tight. So I guess someone out there somewhere, if you can think of it, someone's probably done it. But it's certainly not a common thing to have an ear pinning reversal. That is an unusual request and one that we would not do. And I would advise a specialist ear guy to even talk about that. I don't really know how to advise on that one. Can I have a breast reduction and a tummy tuck if I am on HRT and citalopram? So citalopram, no problem at all. HRT, the problem is the DVT and PE, which are risks of those operations, particularly tummy tuck. So that is a risk. Again, it is a relative contraindication. It is not an absolute contraindication, at least not in my practice. It's not I wouldn't say no just because you're on HRT. Some surgeons will ask you to stop your HRT 6 weeks or sometime preoperatively. I don't ask people to stop their HRT because there are consequences of stopping the HRT. So I say carry on your HRT. However, I will counsel you about the risks of DVT and PE, and we will do lots of things to reduce that risk with Flowtron boots and stockings and keep you moving basically, and then heparin injections. And the best thing is to get you up and walking, which we would do with anyone, but probably lay it on a bit heavier with you if you're on HRT. So it's a question of just getting you up and moving as soon as possible. If not the day of surgery, definitely the next day. And when you're not doing anything, keeping your legs moving or what have you. So yes, you can have those surgeries on those medications, but you have to keep moving. Also, again, we'd have to talk to the hospital. The hospitals are fine with it. Because in these sort of higher risk cases, like the other day when we had a patient who'd had a cardiac arrest before, it's better to do it in a bigger hospital. The problem is the bigger hospitals aren't doing cosmetic surgery, or at least the bigger hospital near where I am, which is the Priory Hospital, is basically not doing cosmetic surgery. Pretty much full stop. I think they're just not doing cosmetic surgery. They've got a lot of work with the other surgeons, and so that is an issue for situations like this. We have had situations where we've had high-risk patients and they've let us do it there. Well, I'm talking about it as if it's plural. It's not. It's happened once. So, and they let us do it there. That was a few years ago. But then we had another one more recently and they said no. So on paper, you can have a surgery. In real life, whether we'd have to talk to the hospital, anaesthetist, etc., to make sure everyone's happy. Because they've all got to be happy. How long after having inverted nipple correction can I resume kickboxing? Blimey O'Reilly, kickboxing. I mean, presumably someone will kick you in the nipple, won't they? They do those high kicks with on a nipple kick. Oh, God. Nipple kick after inverted nipple correction. Oh, my God. That's got to be a submission right away there. God, if they find out you've had an inverted nipple correction as well, can you imagine it? They'll go straight for the nipple crippler, straight in. Having said all that, it's not actually that bad in inverted nipple correction. It's often quite a bit of bruising, but the actual incision is tiny. It's just a little incision at the base of the nipple. 6 weeks minimum. If you're going to get a proper kick, should I say longer than that? Should I say 8 weeks? Maybe I should say 8 weeks. When you're okay to get a proper kick in your nipple. Yeah, 8 weeks. Can you wear like sort of like nipple shields that sometimes people wear because they don't like the nipple showing. If you can wear those things, I don't know. I'm not familiar with the kickboxing regulation. I'm not up to date with the latest kickboxing attire regulation. But if the National Kickboxing League allow, I can give you a note if that's helpful, a doctor's note to say you've got to wear a nipple shield. Obviously, just silicone. You want like a metal one, but you know, yeah, 8 weeks, 8 weeks. I'd say I'm going 8 weeks. Will you offer liposuction to the upper back area and under the bust? Yeah. Upper back, under the bust. What do you mean? Is it so? It's under the bust, upper abdomen. So under the bust, definitely. Well, both of them definitely. The only thing about upper back, the only thing when it gets into back liposuction is what I normally say to people, and it depends on what you're having done. It's often combined with another procedure. So if it's combined with another procedure, you've got to think about positioning because positioning can be an issue. And what I normally like to do is to do the liposuction as much as I can do with you on the operating table like that. So as long as we can sort of roll you a bit, and that's normally okay for people because most people you can get round to the side. Now you can't get all the way to the midline. You can't kind of get over the spine, but not many people are not, have got like liposuction over the spine, problem. So normally it's kind of here, but it's obviously something we'd have to have a discussion with to check that those areas that I could address would be happy. You would be happy having those areas addressed, and I wouldn't get all the way to the back. I mean, I could. It's just I'd have to turn you. So that's it's an extra level of complexity if you're under anaesthetic and we have to turn you. The anaesthetists don't like it. It brings in extra risks. So it's better if we can do it just by sort of moving like that. Have you got a long waiting list? You're again. I don't know if I'm saying that right. You're again. I don't know. You're again. I don't think so. Months, couple of months. I don't know. I don't deal with that. I've got enough on. I don't know if you can tell. I've got a lot on. I've got enough on as it is. Weight of the world on my shoulders. So I don't know what the waiting list is. But Amy at the clinic is the font of all knowledge on those sorts of questions. So Amy will be able to tell you like that what the waiting list is because she is on it. So give her a call tomorrow, 0121 454 3680, and she will for sure be able to tell you about the waiting list, or message on Instagram because she picks up the messages and stuff. Facebook is in the house. Sarah Marie, what you got? Amy is amazing. I know she is, yeah. Sarah, can I ask you a few questions? Yes, you can. I have a hole in my armpit. Oh my God! From arm reduction. Oh, good God! And the docs are saying I have a contagious infection too. Could you please have a look at my armpit pictures? See what you think. Ooh, heck! Where are your armpit pictures? Brad's in the house. Brad, just proof of life. Well, I'll certainly have a look, Sarah Marie. My thing with this is always to say to people, go to the surgeon. I'm assuming I'm not your surgeon. If I'm your surgeon, come to see me. But I would say go and see your surgeon. I'm not sure what a contagious infection, what that means. I know what it means. Hi, Brad. I'm doing all right. It's good to see you. Good to see you, fella. Have I aged? Amy is a credit. Yes, she is, Colin. Absolutely. So yes. So it's difficult, Sarah Marie, when you have a post-op kind of complication. I guess this would be classed as. You really need to work with your doctor about that. It's you don't really go on to another surgeon sort of thing, but for sure you can. What are you going to do? Send me a photo on Facebook, like message or something. You're welcome to send a photo on Facebook message, but I probably will say what I'm going to say, which is still not a day for 21. Come on, bro. Look at the state of the beard. Look at the state of it. It's white. Oh. So I will say you need to talk to your surgeon, work with your surgeon. I'm not sure about the contagious infection thing, but you might have an infection. If it's kind of red and angry, in which case you need some antibiotics and dressings. And these things happen, Sarah Marie. It's all this kind of stuff is closed tight, you know, when arm reductions and stuff is closed tight, armpit, hot, sweaty area. So it is unfortunately a sort of an established complication of arm reduction. Oh, what we got? The infection is Klebsiella pneumonia is the infection. I will send pictures on Facebook. Okay, well, that's good. So you know what it is. So that's a good start, Sarah. So you have an organism. So presumably they've swabbed it, which is great. And so they can treat it. So if it is infected with that, that's the first thing to say, because sometimes people will swab a wound and get a result. Just because you get a bug there doesn't mean it's infected. But if it's sort of red and angry and, you know, unpleasant, then probably it is infected. And then you probably need to use some antibiotics which will treat Klebsiella pneumonia. Would be the armchair advice from this plastic surgeon, but I would stick with your surgeon because he or she knows you and knows your armpit and will be able to sort of see how you're doing, you know, see sort of you know, kind of, you know, every day, or maybe not every day, but see progress. You know, when you look at one off, it's kind of hard. When you just see it one off, you think, oh my god, that was good, terrible, that was brilliant, or that was, you know, you need to say, oh my god, it looks bad now, you should have seen it last week. So, oh, fantastic, it's looking better. Or last week it didn't look too bad, this week looks worse, and crikey, it's getting worse, you know. So yeah, I'm not sure how much help I'll be, Sarah Marie, but by all means send me a photo. The other thing I'll say to you is eat. Very important. Nutrition is important, and try and stay positive. It is still, I don't know how long after your operation it is, but it is painful both physically and emotionally when these things happen. I've sent you some on Messenger. Okay, well, I will reply on Messenger, Sarah, but the bottom line is stay strong, sit with your surgeon, and good news that you know what the organism is, and yeah, good luck, really, because it is horrible, miserable when these things happen, isn't it? Which brands do you use for breast enlargements? I'm assuming that means which brands of breast implant. I'm assuming. I don't use any. Well, I'm not tied to use any one manufacturer. I don't have to use any one manufacturer. I'm not like some companies have got deals and stuff with whatever. Some surgeons have not even with a deal, they just have a thing that they always use Mentor, or they always use Nagel, or they always use whatever. So some surgeons do have a thing where they use, I will use any, and I use all the different types of implants. I use smooth, textured, micro textured, macro textured, polyurethane implants. I use them all, and I offer them all to my patients. I do have makes that I tend to use. Polytech is probably the main one because they're the only ones that make all the different types of implants. All the other companies will only make one or two different types of implants. But if you have a view and you say, look, I like this make or that make, and as long as the hospital can get it or we can get it, then I will use it. But Polytech I like. I use Nagel. I used to use a lot of Nagel, and less so now, but I still use quite a bit of Nagel. But I've used Motiva, or I've used Allergan, who are no longer around. I've used Mentor, which is another big company. So, you know, there's a lot of big companies, and some, if you have a view on it and you think one's better than the other, fine. Not sure if there is tangible proof that one's better than the other, but for me, it's just what you're comfortable with and what the range you're used to. But certainly happy to accommodate if someone's got a view on a certain make. But Polytech and Nagel, bit of Motiva if it's a micro textured. But yeah, as I say, happy to use Mentor. Yeah. So those are the brands. Do you think you'll ever operate in Birmingham again? I think so, Corinne. Yeah, I think so. I hope so, because it is a bit of a thing going on. I mean, as I say, I'm not complaining because it is nice to have a place to operate. So it is nice, and it's not that bad going up to Liverpool. But yeah, I don't know. It's interesting. Who would have predicted that we would not be operating at the private hospitals? Who would have predicted it? Not me, that's for sure. It's certainly not any looking like it's going to come anytime soon. that snake. So, sorry, I'm just. But I hope so is the answer, Corinne. But I don't know. It's amazing, but for traveling, Birmingham is absolutely. But I think it's for sure for everybody. But for everybody, it's easier, particularly people who are coming to us south. It's a real. It can be a bit of a journey. So yeah, I hope so. I can tell you now, I'm not going to make my own hospital. I've decided that a while ago, but more and more people are, and yeah, they're very good at assets. So yeah, no complaints. But yeah, it would be nice. I have a sebaceous cyst on my face, and I would like to know any other method to cure it other than surgery, as I'm afraid there'll be a scar after the surgery. I have not got one. A lot of these people, YouTube is rife with people wanting to know how to do this at home, how to remove a mole at home remedies, cider vinegar, or God knows what they want to put on these things. I mean, if you think about it, I mean, what it is, it's a walled ball, it's a cyst. So, I mean, you can lance it, you can put a needle in it, you can have stuff come out of it, but it's not gonna get rid of the wall, and that's the problem with cysts. So I don't know of any other way of getting rid of the wall of the cyst without making a cut in the skin and taking that wall out, and then it's gone. I can't even in my mind think, even in Star Trek, how they could take that wall out without getting it through the skin. How do you get that? It's like a little marble. How are you going to get that marble out without going through the skin? Go the other side. Now, if it's in the mouth, you might be able to go the other side from the mucosa. But, if it's on your head, what are you going to go in the brain, go up your nose and through your brain? How else can you get it out? I don't know how else you can get it out, is the answer. So I can't see any other way. As I say, there are ways of sort of deflating the cyst by lancing it or putting a needle and aspirating it. But the cyst wall remains. Now, if they would, sometimes I know people will sort of deflate the cyst and then try and take it out through a small incision, fine, if they can get all the cyst wall out. But it's more difficult when the cyst's deflated, and if you don't get all of the cyst wall out, it can come back. That's the problem. So there, in my experience and in my view, there is no other method other than surgery. But of course, and I totally understand you don't want the scar. I mean, no one wants a scar. You say to anyone, do you want a scar or not? Here's two options. Do you want a scar or no scar? I'll have no scar, please. Well, everyone's going to choose no scar. But then, do you want a cyst or no cyst? So you either have a cyst with no scar, or a scar with no cyst. Those are the two options. I don't know of an option of no cyst, no scar. If there was, we would do it on everyone. It's not like there's some magical option that's like, oh yeah, I've got this thing where I can just vanquish the cyst. There isn't. It doesn't exist in my experience. If you find one, then let me know. But presumably you're asking a question because you haven't found one. And yeah, I completely understand how you don't want the scar. So it comes down to how much does it bother you. If it doesn't bother you that much, that's it. Leave it. It's not going to do you any harm, probably. As long as you've had it checked and it's just a cyst, it's not going to do you any harm, and it will sit there. It might get bigger, it might get smaller, it might get infected, it might not. But but if it bothers you enough, then have it removed. It's on your face. Paradoxically, is that the right word? Paradoxically, but the scars on your face tend to settle really well. That's quite a good thing. That often people think, oh, I don't want a scar on my face. Actually, scar heals a lot. The scars on the face heal a lot a lot weller than scars on the body. So if it was on your back, or if it was on your shoulder, or if it was on your chest, I'd be more worried about the scar personally than on your face. The face does tend to heal well. We try and hide it in a natural wrinkle or line. Young 20-year-old like myself hasn't got any wrinkles or lines, so obviously hard to hide the wrinkles in a youngster like me. But I don't know if you're an oldie and you've got some wrinkles, or if it's in a good place where there's some natural shadows, natural creases, we might be able to hide the scar even better. So kind of depends where it is on what sort of scar we can hope to achieve. So that's definitely something we could talk about. But if you don't want a scar, then you're at the no scar cyst camp. You know, the other camp is scar no cyst. I can see an algorithm there. Let's see if it picture it. No scar cyst, scar no cyst. But you know, like the justice scales of justice type thing. I can see a TikTok coming. That's a TikTok there, isn't it? Scales of justice. Scar no cyst, no cyst scar. You choose. Asset is amazing. Traveling Birmingham would be easier. I'd love it if you had your own theatre, Turkish Delights on tap. Corin, no. Turkish Delights not on tap. I am banned, Corin, from the Turkish Delights. I am not safe around Turkish Delights. It is not a viable option. That I think Amy confiscated the stash, half of the stash you bought last time, so it is not. It is not advisable to put Turkish Delights anywhere within a 3 feet radius of yours truly, because they will disappear. So there we go. That's it. I don't know about you. I'm exhausted. Maybe we'll have a short one next week. Who knows? I shouldn't say that. God willing, the questions will still come. Please ask the questions. Sarah, I'll have a look at your photos on the messenger. Good luck with your armpit. Corin, sorry. Don't be sorry, Corin. Don't be sorry. You'll never get any complaints from me, I tell you. I love them, I do. I will be, thank you. Great to have you back. I made a new friend today, the Staiano Clinic, bringing people together. Yeah, community. Yeah, solidarity, sister. Come on. Good. That's good to hear. So, all right, people. Right, followers. All right, my followers. Go out into the world, do good things, and I'll see you next Tuesday, 7 o'clock, same time, same place. Hasta la vista, and I bid you good night, Corin.